it would help you in scoring better marks after you are doing this. Okay. So I project the instrument. I request people to not in a group, but one by one. On this side we start. So you can tell me the instrument. So, okay. So shall we start? Now we start with the ear instruments. So can somebody tell what is that one? Yeah. It's a rectus. With the reference rectus as the option on 4. You will find as flat end here. It will not be like a probe. Other side there is like a option on 4. Okay. So the rectus is a compartment for forceps. So next, somebody, my company says something. Okay, you want to tell collectively? Fine. What is the instrument on the left side? Release. What is this one? Yeah. This is easy for you. Release oral forceps and equals pneumatic speculum with bulb. Okay. So this, what is this one? What is this one? There are three different types of oral speculum. I have the proper name. See, postgraduates, we expect them as the names because people have struggled to design these instruments. Remember, they spent their lifetime to make these instruments. We are using it today for easy examination or easy surveys. Okay, so we need to remember their names who have designed this. No, these are beauty. This is home praise, right? And this is Pulitzer's merry-go-round. This is Hartmann's oral speculum. This is Rosen's oral speculum. Okay. So Rosen's has got a slot. Okay. Now, what are these? These are Gomet tubes. What is this tube? What is this tube? What is this? This is called as Parabos. No? Okay. That is Shepherd's tube and Shah's tube. Shah has got a long one flange. It's a longer stem tube. And this is Parabos mastoid periosteal elevator. You can tell the complete name. It is that is Parabos mastoid periosteal elevator. It is what a thumb rest. You rest the thumb over here to elevate the periosteum. So what is this? Okay, this is that one. One side you will find that is molluscans, this is clusters. Mastoid reptile. Okay. This. You need the proper names. Okay. So the Lampert's endoral speculum used for endoral incision. Right. This is house graft press forceps for pressing the graft. After harvesting, to dehydrate the graft, you press it. So this one, cell-seeker liquid. What is that name? Maculatus. Right? What is this? This is Shear's micro ear ball probe. You find a small instrument. This ball probe. This is sometimes very useful to break the middle ear adhesion. Suppose in the middle ear, find the determinant and this one is there. You want to check any adhesions are there in the institute before putting a graph. Ventilation of the middle ear. You can use a ball probe. It's a gentle probe. These are the pricks, patrons, micro ear, pricks, patron. This you must have seen names. This what this one? Yeah, Lester's improvements. Lester's flat knife and Rosen's curved knife. For my creativity. This one, stapes surgery, unit, house ear with micro unit. Bony overhang, removed. This one is alligator forceps. This one, you know where this surgery, it's used for holding ossicle holding. Yes. So Wolstein's forceps, that is the cup forceps, and that's the Dalekis ossicle holding for ossiculoplasty. This one, yes, right. That is the name. You have to remember the names. House dieters. House dieters for Alice Liver. So we'll go to the nose now. So you know all of this. This is what becomes. That is Pillion's self-eating. Becomes and Pillion's self-eating. This one. Template forms this one. Ballinger fuel line. Where it is used? Where is it used? Nowadays, where is it used? Submucosal resection. So nowadays, most of you are doing septoplasty. If there is an indication for submucosal resection, what is the indication for submucosal resection? Anybody? Posterior septal deviation. Okay. So Ballinger's swivel knife. Swivel, it's because it rotates. If you see here, there is a knife here which rotates 360 degrees. So this is not clear. At least for what? It's a little bulkier. Here should be thinner. That is Pillion's nasal gauge. There is a difference between Pillion's and this. What is this one? See this and this. What is this? It's a Tilly's gauge. Nasal gauge. And deep mallet. Don't call it a hammer. Okay? It's a mallet. Test instruments. Pillion's curved suction tip. Legacy means straight cup forces. No? This one. What is the advantage of through cut? Mucosal sparing. Okay. So it's called as Legacy's through cut process. And this is Legacy means upturn, cup forces. Okay. This is again a 90-degree process. As far as legacy concepts only, there are two different ideas. Can you tell me this one? Which one? This one? Ah, name. Yeah. Which surgery is used? Where? Which part of the endoscopic site? Huh? Uncinectomy. What is the name of the uncinectomy? It is called as reverse uncinectomy. Okay. Ostrom's backbiting process. Okay. It's upwards. You get it sidewards also. This is upwards. This process, which is very useful for us, in which surgery is used. Yeah? Frontal? No. Anthropoid polyp, it is very useful, especially to be inside there, the attachment of the antral part of the acid anthropoid polyp. Very U-visor process. Right? And this one, this compared to Blackesley, this is a scout process. This is called as Tilly Records process. This you should be able to tell. This one, where is it? What is that instrument? See? Caudal sinus, sphenoid. Sphenoid it will be straight, caudal it will be like a giraffe. So this is Kerecis orangia, that is Camberger's mushroom process. It's like a mushroom. This was designed by Scamberger. You know who is Scamberger? Endoscopic sciences. He has popularized. Right? Please. Any difference you can make out? This is curve. This is Hedgehog Cochlear's sphenoid punch, and this is Kerecis Cosmos orangia. There is a slight difference in these two. Sphenoid punch, where do you use? Where do you use? Sphenoidotomy. So you enlarge the angle of the sphenoid, opening of the sphenoid or widen it. So this one is something like a graph. Bone gas frontal sinus giraffe. This is a common instrument of course. See? Yeah, what is the name of that? See the proper name. Cayman. Okay. Remember these names because they spent their lifetime designing these instruments. Right? This one. This is calciums. This is ashes. Specifically put that they don't match. This is not ash process. Yeah? This is Jensen's bone nibbler. Okay. So when we started doing mastectomy, initially we used to do the mallet and root. So to remove the bony ridge, we used to use this bone nibbler. Okay. Later came the drills, micromotors, and other things. I still remember, yeah, we used to do mallet and root. Mallet and root. But this tool is useful for removing the bone when we are doing a lateral anatomy. We want to remove the median wall of the maxilla. Okay. Then for cardiac operation also. Right? So this all in the Walsham's process. This is for the median wall or the lateral wall? Lateral wall. We used to spend our lifetime manually doing these procedures. We have done 20, 25 per day we used to do. What is the name? Huh? Trocar and cannula. Litchfields, Kumar and Kerala, they no longer are in use, but they do have a role in some of the cases. But they used to do at least 20-25 cases in every minority, these after washes cases. Now those are all gone. The concept of sinusitis, sinus treatment, and everything has changed. Okay, so it's Litchfields, Kumar and Kerala. And this one, it's a double action forceps. Jensen medicine circumforceps. So double action, there is a double action here and here. So when you press these two, then it goes. You must have seen in the OP. This one, cephaloplastic, or only the bone is curved for a thick bone, right? So this is written circumforceps. So this is ash forceps, right? This one, name. Ashes circumforceps. Illness, ala retractor. Illness, ala retractor. This one, this is office retractor. Okay. What is this? The other one? Foreman's ala retractor. Okay. And this is the office retractor for rhinoplasty. These are the rasps. Again, rhinoplasty names. Office force rasp and Joseph Fine rasp. They are big names in rhinoplasty, especially Joseph Fine. This one. Rhinoplasty again, osteotomies. Nasal chisel for osteotomy. This, this is Boyle's Davis. This is Doughty's tongue blade. Doughty's tongue blade. Davis Boyle's mouth blade. Okay. Now, this one. You are teaching the undergraduate very well. It's like they are taking classes, for undergraduate. Ligament plate and separate Thompson sediment fluid. This one. You can see that one. Sinclair Thompson's Quincy forceps. This is Ryan's mouth gap. This is for foreign body bronchus. Hopkins optical forceps for bronchoscopy. You must have seen, ENT hospital is having this. So this is for removal of the foreign body bronchus and the lesion. We had a video foreign body this one for microlens surgery. Sahasra suspension laryngoscope. And this for home focal cord and false cord retractor. Okay. What is this? Name. Cross use. Identify that. What is tracheal stenosis? Montgomery QT. And this is cross use tracheal dilator. is this process? What is that? Which is this? What is this? This is a post-laryngeal voice rehabilitation. No? This one, the two tubes here, that is Bloom's sinus. This one, Fovox. Fovox voice prosthesis, Bloom's sinus prosthesis. That is a picking function, primary and secondary, that was discussed. So these are the few instruments I thought I will show you. Then some of the radiology. So radiology mainly X-rays. You see, the role of X-rays is not unbound nowadays in our ENT practice. They have a limited role now in modern imaging. Most useful in case of foreign bodies, and as you know, digital X-rays are now preferred for clarity and better soft tissue and increase visualization. So I'll show you some of the rare X-rays commonly you may be seeing. So what is this X-ray? Lateral view of neck, anything abnormal? This is a normal lateral view of the neck. Don't mistake these calcifications from the foreign bodies. Here, right? And the theoretical space, the vertebral bodies, the curvature of the spine, all these things tell a lot of things. Sometimes you may not see a foreign body, but it will be straightening of the spine due to pain and all. So this is a normal. So here, you are seeing here, this is a plain X-ray. Whenever you are asked to answer an X-ray, you should talk about whether it's plain or a contrast, right? And what is the area which is displayed, the X-ray, and then talk about what is the pathology. So this is a plain X-ray, lateral view, soft tissues in the neck, showing the linear radiopaque shadow. Where is the radiopaque shadow? Opposite the 1, 2, 3, 4, 5, 6. 6 layers are like a spine, right? What it could be? It could be anything. It may be a bone, it may be needle, it may be a wire, it may be anything. Okay? So how do you know it is an abscess or a foreign body with an abscess or a foreign body? You will find a hair shadow around it. So read this X-ray. This is a plain X-ray of the neck, chest and abdomen, showing a circular radiopaque shadow in the lower part of the neck. See, the moment you see the X-ray, don't jump and say foreign body, foreign body. When you are asked to answer, you are supposed to talk like that. So what it could be a coin, it could be a battery, it could be we have removed a lot of foreign bodies like this. So how do you differentiate the battery and a coin? So this is a sign. This is a very, very important point of the halo sign. You see very clearly around the circular radiopaque foreign body. It is an emergency because it is going to perforate. It is going to destroy very fast. So it's an emergency. Right? Now here, read the X-ray. What is this view? Lateral view of the neck and of the chest. And this is the lateral view. So what is the finding? Circular radiopaque foreign body seen in the trachea. Okay. So like the esophagus, this is the trachea. How to differentiate want to make out whether it's an artifact or a real foreign body. Sometimes you not receive a lot of things in X-ray, but it can be an artifact also. Here, X-ray of the chest and abdomen. Again, you see a small radiating shadow, probably in the right side. It could be on the radiology table. This could be on the radiology table. It could be, yes, it can. So you should have a letter with you also. But this was in the right main box. Now, what is this X-ray? X-ray again of the child. You can see nicely the lateral part of the skull, neck, and upper chest. We are confused. Patient was saying foreign body, but we are not seeing anything in the oral cavity or the. So this was a key in the nasopharynx. See, you do come across. I'm telling you, we came across a lot of foreign bodies. Where I was working here in ENT hospital. We had a brush, we had a key. I'll show you. We'll do this. Right? So this was a small child. So you should never forget to look at whether a foreign body is in the list in the nasopharynx. So always include the skull, the nasopharynx also, not only the neck, in the X-ray. So this was a clip of a mother in the nasopharynx again. Mother's hair clip. This was a small ring, again like a coin was lying in the epipharynx. Okay. This one, as I told you can see a fair shadow around the foreign body. So, retropharyngeal abscess going into an abscess. Okay. So here, see the distal X-ray, how nicely you are able to see the structures like the epiglottis, the hyoid, the base of tongue, the transparent thyroid cartilage, retropharyngeal space in the foreign body, and you can see the. This was again a patient. He was a metal worker. He was welding. A small chip of the metal went into his neck, and he had this on the X-ray. This is again a soft tissue, foreign body, metallic chip in the neck. These are the most difficult foreign bodies to remove because when you explore, you will not find it. You may need the help of a C-arm. This is a cool drink bottle cap, right? Can you see the image on the X-ray? This was the needle. This you put it on the board, pinning board pin. That was in the bronchus, right side. And this was the patient. Very interestingly, we casted a single shadow and we removed three or 4 points in the same place. They are overlapped one by other. One of them. It's accurate. Right? One was in the abdomen. One was outside, by the side of the patient. It was not in the hand. Okay? And here there are multiple points. Right? And this was the shadow X-ray of the brush in the nasopharynx. I'm showing the video. I'm not playing here. I'll go back and go to the I will show you before the video. This is here, we're seeing the endoscope inside. is the broken tooth brush inside the nose. From the nasopharynx, it's projected inside the nose. This was the child. Now, how to remove this? You can treat from the other side. You cannot catch and put it into the nose. No? So we have to retrieve it through the oral cavity, pushing it down. Don't stop quick. These are the adenoids you see. So we are trying to push, and it clears the pharyngeal wall. Then we again have to disinfect, then push it. It's not easy. It's actually, I see that it is going into the station tube. No? It's not easy. From the other side, the suction is introduced, then gently by pushing it down slowly and up, you could remove the formula. This was another foreign body. This they wear over the neck, small sleeve. It was stuck in the supraglottis. You can see stuck in the supraglottis here. Here you can see the shadow of the foreign body. Right. The radio simple X-rays are also useful for cochlear implant. So we take an X-ray after a post-operative to look for the position of the electrodes inside the cochlea. Transorbital view called this. So this was a patient who had the electrodes in the eustachian tube. We did a cochlear implant. By mistake, we put the electrodes into the eustachian tube. And this actually happened to be done here only. It was the 150th case. And we were all celebrating, we have done successfully, and oh, cake, pastries, and everything has come. So switch on, we came to know that the implant is not working. So we took an X-ray. You see the electrode here, they're in a straight line going into the eustachian tube. So we redid the surgery, removed the electrodes, and put it back into the cochlea and took the post-operative. You see nicely the electrodes are now poured inside the cochlea. So main X-rays may be useful even for cochlear implantation to post-operative to evaluate or placement of the electrode. So it is cheaper than a CT scan. Dust imaging for foreign bodies of the upper end of the and used only when foreign bodies are ready open. These are basic. Thank you. And this was uploaded tribute to our Gandhi people working during the COVID time. It was a really wonderful meeting on that day, and it was a really great gesture of the country and the people who have visited us. The next topic for today is by Dr. Anand. I request Dr. Anand illustrate to give a moment of this. Thank you very much. I request Dr. Anand Acharya sir to visit his audiology to take topic actually. Sir will enlighten on the clinical audiology.
This is some confirmation from your brain cells. I've been exhausted. This is the usual way we are learning. It should be long term. But it's cramped in the last minute. Morning to now. So I know you're all saturated. So I have to make it simpler. So some of you may have heard this topic last year when I presented. This year there are two slides I have added. To start with, I'm not going to the physics of this. If you start it, 5 minutes the room will be empty. Because it's you have to come to MBBS because we don't like mathematics and physics. But we are forced to this also when we come to ENT. So there are so much of sound, physics. If you want to go to software and event like certificate, then you have to really love it to get the best result of it. So if somebody asks me, draw a diagram of pathway of hearing, I give 100 out of 100 to the person who draws it on both the sides. So the sound heard on right ear is interpreted also with but if it's a whole, then you have to right to left. That can be diagnosed by some happenings of the left ear. So this is the pathway of the sound. As in sound comes from the ear, through the external canal, through the ossicles, and then there is a stimulation of the auditory nerve, which has got bilateral bifurcation, both the sides will be stimulated. From there, facial and also the sound will be picked up from the other side also. So this is a pathway of hearing, in which this is very, very important for you to understand the acoustic reflexes. So this is the basic pathway. I think most of it can be read in the books. Then what is the role of audiology? Why should we learn about audiology? Because it gives you the assessment of the amount of hearing loss a patient has, the type of hearing loss a patient has, and it discriminates where exactly is the hearing loss, so that when you are prepared, when you do surgery, what exactly you are going to do, it will give you an indication. Then for medical legal purposes, it is absolutely necessary because a simple surgery like exploratory tympanotomy has produced 1% total hearing loss. Just opening the tympanic cavity by elevating the tympanic flap and closing it back has caused in a normal ear also. So if we don't document this before surgery nowadays, then patient may say that the damaged the ear which was supposed to be normal. But if you have a documented it was already abnormal, then the complication of surgery can be explained. Then prognosis of the of hearing loss. Suppose somebody is going to work in a factory, in a place where there is high noise, or he is going for undersea exploration or undermine mining fields. At the time of employment, he should have a audiometry record as the disease progresses as is exposed to the noise, then if somebody has got high sensitivity to loud noises, may have early onset of noise-induced hearing loss. So this is where it is going to help. So in occupational health, all the people who are going to join in the factory are supposed to have a document of this, because they can sue the management later that because of your factory, I got deafness and I was not informed before, then that happens in cases. So whenever somebody comes, this is the prognostic thing we can think about what is the role of audiology. So now audiology, how we assess is, can be a subjective type of audiology or objective type. In subjective, you need the patient's participation, whether you can hear the sound or not. In objective, you don't need the patient's participation. We can do everything by the responses of the ear to the sound. Again, there are two types here. One is invasive audiology and another is non-invasive audiology. The invasive means there should be some penetration of the hearing, which is the ear. And in others, there is no invasion anymore. So after the patient does not have any change. But in the case of invasive, there is a test called as electrocochleography, where there is a transtympanic electrode. But nowadays, even that they have overcome by putting a electrosensitive instrument over the tympanic membrane so that they can do it truly non-invasive. So the invasive one is the electrocochleography. Then when we come to the subjective type of audiology, there are various types of tests in subjective audiology which can be done under pure tone audiometry. In pure tone audiometry, again, there are many other types of tests: speech reception threshold, speech discrimination score, short increment sensitivity index, alternate binaural loudness balance, tone decay, and frequency audiometry. All these come in subjective audiometry, where the patient has to participate when he is doing when he is undergoing the test. In the objective one, where you don't need except the patient's ear, and he should be still. If he is not still, as you know, many of the infants who come to us for hearing loss, they will be given some sedative so that they are still. Because if they are moving around, muscle artifacts will interfere with the test. So, except for that, you don't need any other thing. The tests in this are impedance, photoacoustic emissions, brainstem evoked response audiometry, and there was again a cortical evoked response audiometry which has not become popular because it is very difficult to get the results foolproof. So this is the pathway of hearing which all of you know: air conduction, bone conduction, how the air is going along the exnotory canal, and the bone conduction directly stimulating over the mastoid cortex. In pure tone audiometry, we will have a sound delivered through the earphones and a bone vibrator which will be kept over the mastoid process. So we will have air conduction, bone conduction, both being tested in pure tone audiometry. So without going into all the details, what is a pure tone audiometry? It is done in a sound treated room because it is practically impossible to make a soundproof room. So whenever somebody says there is a soundproof room needed, it is not so. You can do it in a sound-treated room where the amount of background noise is already calibrated by a noise detection machine. So the amount of noise in that room should be detected from the thresholds which you get from the room. So that is a sound-treated room in which you have a machine called as audiometer. So you get a report called as audiogram. So this audiometer has got two attenuators. Attenuators means increasing and decreasing the sound. Then it has got a sound generator which will generate sounds from 250 usually, or even sometimes 125. Some of the audiometers can do up to 20,000 depending on the purpose you want. Most clinical audiometers have got sound generation from 125 Hz to 6,000 Hz or 8,000 Hz. So this delivers a sound which is also called as pure tone. That means a sound of that particular tone, and there is no other tone in that. If all of them are mixed together, it is called as white noise. If all the sounds, if all the colors come together, it is white. And when you separate the colors, it becomes different colors. In the same way, the sounds are shifted from all the white noise to different frequencies, and each frequency is tested at one time. We have 125, 250, 500, 1000 hertz, 2000 hertz, 2003, 4000, and 6000. So the recordings which you get in a normal condition are air conduction and bone conduction. Most of the time they overlap, and then if you find a audiogram in which air conduction recording is above bone conduction, you should never trust that, because air conduction is always on the audiogram. Now I will come to something else. When you are doing a tuning fork, air conduction is better than bone conduction. But on the audiogram, the air conduction is below bone conduction. So what does it mean? The depiction of the threshold on the audiogram is a negative logarithm of two reference sounds. There is nothing like zero sound. There has to be sound. So the amount of sound delivered to the ear with reference to a sound and the threshold at which the patient hears the sound is recorded to the reference sound. Then what is a normal ear? A person 25 years of age, not exposed to any loud abnormal sounds, the thresholds recorded for that person at 25 years of age is considered as a normal ear. So the reference is for that. So all these are references compared to a zero or reference for us. So this is the reference. So there has to be air conduction, bone conduction, there will be overlap. And as you know, I'll come to this signal. And then on the right side of the slide here, you'll see the recording for the left ear, in which you will find a distance where the air conduction is fallen down compared to the bone. That means air conduction is less than bone conduction. Then what are the various signs? So how do they do the recording? First time, what is the patient is explained after putting the speakers or the speakers to deliver the sound to the ear. That he will hear a sound, and then that sound will be increased and decreased at the threshold in which the patient says, I will hear and I cannot hear. So that is called as 5 degree plus decibel, 5 degree minus 5 degree decibel plus 5 degree decibel. So first, usually they select a sound of 1000 hertz. Then is made to learn the sound by delivering the sound at a higher threshold where you can perceive the sound. Then we bring it down alternatively. Then at one stage he cannot hear. Then again 5 decibel more is stimulated. Then he can hear. Then it is brought down again. Then he says I cannot hear. That is how the threshold is recorded. Got it? So that threshold of which the patient is done, they bring all the various frequencies. 250, 500, 1000, 2000 and all. So what are the various symbols on the audiogram? So the last record is the color code. Right is red, blue is left. R, blue contains L. So L is blue. Right is starts with R is right, red. So if you get an audiogram where you find somebody putting with red ink and blue ink, you should be giving good response or good consideration for that audiogram. Then sometimes they will say test conditions, fair or unfair. Some of the patients may not cooperate. So then you write the test condition unsatisfied. Then the various things are on the right side. If you find a right red open circle, that means it is for the right ear. Blue cross is for the left ear. Then masking and unmasking. If it is masked, it is a triangle, and on the left side it is a square. No response. No response. Arrow going down means the patient's hearing threshold is so high that the limits of the audiometer are already crossed. That means he cannot be tested by the audiometer available to that person at that time. That is no response. Then BC is bone conduction. On the mastoid, the vibrator is kept and we are asked to conduct this type of sound, masking and unmasking. Unmasked sound is pointing to the right ear, pointing to the left ear is V. V is pointing towards away from the left side is like this. So imagine like this. So if it is a bracket, this bracket is for the right ear, this bracket for the left ear. That is how it is easy to remember. Again, if you have an arrow down, that means the bone conduction is so worse beyond 50 decibels that it cannot be recorded. Air conduction is so low that despite masking it cannot be recorded. Always. So when you get an audiogram, usually what is written here is if it is between 0 to 10 to 0 to 20, up to 20 is considered normal. If you have the recordings in this, it is normal. Then in mind, between these two, moderate between 40 to 50, 60 to 70 is moderate, very severe profound deafness between 9 to 100. Okay, the recordings where they like on the audiogram is the one which will tell you the degree of hearing loss. Then there is what is called as a speech banana, or in the morning they are asking why are you using 512 tuning fork. So the speech banana means the normal conversational voice which you use is distributed in this yellow banana type of picture. The other sounds which they make, the jackhammer, the lorry truck, and the saw, and pistol, revolver, firecrackers, all are above. And very faint rustling of leaves between 1000 to 2000. What we say is the rustling of leaves, whispering. Whispering is between 3000 hertz at 20 to 25 decibel. So earlier, before the audio meter came into picture, there used to be a whispering voice test, conversational voice test, or there used to be and wristwatches which used to be worn, and then they used to keep them near the eye. The ticking of the sound, that's how it was measured. So why it was not reliable? Because whisper means when you are doing a whisper voice test to a patient, what they were supposed to do is exhale and then speak. So that had to be done. So somebody who may not be doing it properly, so that could not be quantified properly. So if you go to the earlier books of hearing assessment, you will get whispering voice test, conversational voice test. So in this speech banana, what we normally speak is distributed between 30 to 50 decibel of hearing loss. You can see that in the speech banana, the maximum is at 500. So in your hearing fork, 512 represents the type of sound usually used during conversation. Once you activate the tuning fork of 512, it continues to deliver sound so that in the meantime you can complete the release test, air conduction, bone conduction, and also your absolute bone conduction. If you take a higher frequency tuning fork, the amount of sound delivered is less, so it will not be enough for you to do the test. And if you go to 256, don't say vibrations. The moment you say vibrations, the user is catching that vibration. Vibration is a sense which is felt. Sound is a sense which is heard. So many times nowadays I find people, particularly from IT or somebody coming, if I do a release test, if I keep it here, I don't say, are you hearing sound? What is happening? We say vibration, vibration. So there is so much of distortion of language nowadays that they don't say I hear sound, they say vibration, which is not correct. So vibration is delivered purely by 128 tuning fork, which you find in neurology and medicine departments. Why? Because diabetes, earlier syphilis were the ones which used to cause loss of vibration senses. Then when you were in medicine, they used to do a 128 one, vibrate it, flip it over the malleolus to find out whether the patient is vibrating or not. There are other conditions where vibrations are tested, which we are not going to know. So 256 also, he was telling this morning that it's not done, but still I find it in Shambo, 256, 512 and 10,024 are the three tuning forks which we are using. So positive, positive, positive or negative, positive, that combination will give you a mild, moderate or severe type of qualitative hearing loss. It's not quantitative. Is qualitative, but they have tried to make it little quantitative by telling if it is heard by 1024, it could be mild, moderate, and severe depending on the tablet quality. Okay. So now the speech banana is also useful when you pick a person with a hearing aid. His audiogram should come between this speech banana. Only then the patient will tell you I can hear better with the hearing aid. Otherwise, you will not be happy with the hearing aid. What is PTA? PTA is pure tone audiometry. PTA is also pure tone average. So average amount of hearing the person has is calculated by adding the three thresholds at 500, 1000 and 2000 hertz and dividing by 3. So we come tomorrow, when you see the audiogram given by our audiologist, they'll write right ear decibel, left ear decibel. How did they get it? So this is how they got it. Taking the average thresholds and then dividing by 3. So the amount of hearing on the right side, left side, they will give you. Then what is masking? Both the ears are connected to each other by being situated in the cranium. So you want to tell something to one side, the other one will interfere. So how to stop the interference from the other one whom you want to keep it aside, that is masking. So last time I told you something by thermometer, anybody remembers? Nobody remembers? Last time I gave you the example. Clinically, to make MBBS students understand what is masking, I told you. Anybody? No. Should I repeat? Repeat. You are a general practitioner. Get a patient of fever. Patient with fever is not telling the history. Attendant of the fever person is overactive. You want to take history from the patient. The attendant is trying to do something. So how do you mask that attendant? Keep a thermometer in the attendant's mouth. Then you can talk to the patient leisurely, according to your heart's content. That is masking. So delivering noise to the non-test ear so that the sounds meant for the test ear are heard only by the test ear. How do I remember this? Because we had a good teacher like Dr. Janardhan Rao, who in his duty by hearted the whole of audiology of Scarborough. And in his duties, we used to listen to him. So one day I thought I should do it. So that's how I learned from my audiology in the duty of ENT. So when you take this line in Scarborough, it will be there. So sounds meant for the non-test ear, okay? So when do you do masking? Because both the ears are situated on the bone on the cranium, masking is necessary for all bone conduction recordings. Because when we do a reverse test, if there is a difference of 5 decibel between the right and left, only then it will be lateralized. If the difference is less than 5 decibels, it will not be lateralized. Okay. And if the difference of release test right and left is more than 15 decibel, then patient will notice it. Because of that principle, masking should be done for all bone conduction recordings. For ear conduction recordings, there is what is called as a crossover. So sounds, if you are delivering sound through the speaker to the right ear, it will cross to the opposite ear when the hearing of this ear is more than 50, then the other ear will begin to interfere with your pitch. So in ear conduction, when the hearing between both ears is more than 50, then you can do it. If it is less than that, if it is 25, 30, crossover is not occurring, then you can take it that this is the year which is giving the responses. Okay? Any doubts till now? Because Last, you will forget the doubts. So if there is anything you want, any clarification, anything to be repeated. So now we will come to the various types of audiograms you will get in your day-to-day practice. In conductive hearing loss, the audiogram on the right side, which is for the right ear, you will see a triangular air conduction, which is masked or unmasked. Just now I told you about the symbols. So unless we practice, it will not come. I'll not go back, but when you're reading again on audiology, just be conscious of what you're reading. And in the exam, after you finish your CSO in case if you get it, then if I tell you to put an audiogram possibility in this patient, you should be able to draw. If you are able to draw an audiogram in the examination, first thing is whether you start from 0 above or 0 below, that is the first confusion unless you have practice. You start from 0 above and come down to 100 below. Then 125 left to right. Then carry 2 frames, put that. Then we know that you know everything about that particular subject. You did not ask anything more. That will be the approach of the examiner. Okay. So now, here in decibel, it is a negative logarithm as the degree worsens, the audiogram air conduction will keep coming down. On the left side, you will see a normal ear in which air conduction and bone conduction, even though they are normal, you see the way they are depicted. Either they overlap or air conduction is always slow, it cannot be more. If you get a recording more than over 0, minus 10 or minus 20, what do you call that ear? A ear which is much more sensitive, hyperacusis, which is very rare. So you need not remember about that. So you got this is called an airborne gap. So what is the airborne gap? It is vowel stress, release stress, and after we do proper surgery, the airborne gap will, should, may close, may not close. Okay? What are the conditions in which it occurs? Continue to read. Then there is an interesting condition in which you get this type of recording. I had a patient recently. So what do you see is a in bone conduction, you will get a take at 2000. It is there on both the sides in this patient. So it is a case of bilateral conductive hearing loss. It's called as Carhart's notch. And somewhere I read that if the notch corresponds also in air conduction, it's a negative Carhart's notch. So a true Carhart's notch should not reflect any change in the air conduction. Is it pathognomonic of autosclerosis? No. So what are the other conditions in which it can occur? What's the answer? Let everybody know. Internal sclerosis. Any condition which causes fixation of the foot plate. Can it occur in venous disease? If there is a hypertender lymphatic hydrops, which is causing stiffening of the foot plate, then it can occur very rarely. Then how do you differentiate in that condition? Now I am going to a little difficult situation. Where you get a Carhart's notch, if patient has to be having a differential diagnosis of Meniere's disease, then what other test will help you to find out? You have to do ECOG. Okay. So this is Carhart's notch. What happens to the notch after surgery? No answer. Does it disappear or you continue to present? I'll give you the answer later. So this is a patient who has got a recording so far below 50 decibel. Both of them have come down. This is a case of mixed hearing loss. And if there is a gap, there is conductive hearing loss. If both of them are falling down, it's a okay. So in a mixed hearing loss, bone conduction, air conduction, both of them should be more than 50 decibels to decrease. Otherwise, if it is, then what is the depicted is a moderate hearing loss, sensory ear type. If the bone conduction hearing loss is somewhere between 30 to 40, it will be mild sensory hearing loss. Get it? Then there is a diagram or audiogram called as cookie weight audiogram, which is found most commonly in congenital hearing losses, where there are islands of hearing loss in the mid frequencies. Then in noise-induced hearing loss, there is a specialty called as aviator's notch or 4 to HKH dip, where 4000 hearing loss is more. Why 4000? For high frequency. So high frequency, how I remember is high frequency situated at the basal tone of the cochlea. So the cochlea promoter is the one which gets the main brunt of the noise. So that's why 4000. Here the beauty is it is both air conduction and bone conduction, both of them do. Okay, it's recording singing both. Then this is called as ski slope, where this is most characteristic of high frequency hearing losses of presbyopia. So what happens? The first up to 2000, he has got moderate amount of hearing. After that, he does not have any residual islands of hearing. So the patient will complain of hearing loss, but he will refuse to accept that he has got hearing loss. He will say, I can hear. So when you go very near to him, speak in very low frequency, loud voice, he says, I can hear. But when there is noise around, he says he cannot hear. This is what is normally the response of the person who comes to us with hearing loss and they do an audio monitoring and he will refuse to accept. So this is the presbyopia I told you. Then previously, before EPUB and all, there was Newton audiometry done in cases of high frequency hearing loss where they used glycerol to decrease the osmolality of the inner fluids. So once you give glycerol and decrease the osmolality, then patients will hear better. So that was the diagnosis made for linear species. So this is a glycerol test, which is not done nowadays, but you can do it for completion. So how do you know that the patient has got linear? Improvement in thresholds by 10 decibels. Speech discrimination score will improve by 12%. Then there is another condition called as recruitment, which is seen in Newton audiometry estimations, where what happens? Abnormal rapid increase in loudness in a ear with sensorineural hearing loss with recruitment characteristic indicating cochlear pathology. It is due to damage of the outer hair cells of the cochlea. So it is seen by doing ABLB test and SI test. ABLB is alternate binaural loudness balancing. So in alternate binaural loudness, increase in intensity of sound disproportionate to normal rate. So when you take this, this is called as a ladder gram, in which in A, the left ear is normal, right ear has got a hearing loss of 20 decibels. As you increase the sound to 10 decibels on the left side, normal side, it corresponds the same way to the right ear. So there is a non-recruiting hearing loss. In the case of recruiting hearing loss, which is in B, the left ear is normal, right ear has got a hearing loss of 30 decibels. As you increase the sound, at one stage, the normal ear and the one with recruiting hearing loss, at one stage, the amount of increase in sound for the recruiting ear is much more. So how do you see it clinically? Whenever there is a patient who has got deafness, like this, an elderly patient, elderly persons at home, when you call them, they will not respond. When you increase loudness, they will shout at you, why are you shouting, I can hear. That is an indication of recruiting. Am I right? Right? Example is right. So this is day-to-day ENT for you. Day-to-day ENT, like ENT in occupations, where smell is tolerated by people working in mortuary, where the first bite of apple is sweet, after that it becomes bland. I'll come to another ENT day-to-day situation. So somebody says, don't shout, I can hear. So what is small increment sensitivity index? A normal ear cannot discriminate 1 decibel increase in ear over a carrier tone. A carrier tone means suppose 1,000 hertz sound is delivered to the ear continuously. In between, for 1 microsecond, there will be a 1 decibel increase, 1/5. A normal ear cannot pick up. But an ear which can pick up will help you in finding out the disease of cochlear pathology. So it detected easily by a recruiting ear. So that helps you in finding out the site of lesion. I'll come to you next. A cochlear hearing loss will pick up that. So what are the causes of cochlear hearing loss? Go to the book. So hearing loss, lateral to foot plate of stapes is conductive, medial to foot plate of stapes was for us sensory neural. Now sensory is different, neural is different, auditory is different, and cortical is different. So over a period of 40 years, the site of lesion has changed. So that is called as differential alignment, in which 1 decibel increment in a carrier tone is heard by the patient. So the person called as Jerger has categorized these type of pitch a person can hear. So a normal ear cannot make out the increase, and the person with cochlear lesion will pick up that pitch 60. Suppose 100 pips are given. After that, the test is stopped. So if the 100 pips are given and the number of pips the patient is able to detect is recorded. If it is 60 to 100, it is a cochlear lesion. If it is 0 to 20, it becomes a retrocochlear lesion. That's how you make out whether the hearing loss is cochlear or retrocochlear. Before the advent of your CT, MRI, everything. So these were the earliest things. Now, because it needs subjects participation, and nowadays nobody has the patience to sit for all this, so they are all slowly going into this routine. Okay, now come to what is called as speech audiometry. What happens only sound in speech audiometry, you should be able to find out the meaning of the word. Just hearing the sound is not enough. It's not correct audiometry. Audiometry is the ability to duplicate what is told to the patient so that communication is good. Right? So in this, there are two types, speech reception threshold and speech discrimination score. Speech reception threshold means the level at which you are able to repeat what is heard through the speaker. So normally it should be 20 plus 20 conversational voice. If somebody has to hear the sound at a louder voice over the normal, the amount of increase in that particular sound, then that indicates the speech reception threshold. So there are what are called as spondy words. In that spondy word, there are two mush eardrum. Like that, sounds are delivered through the speaker, and he has to repeat what he has heard. At one tone, he says he will repeat, then the sound is decreased. If he cannot repeat, again it is gone back. That's how it is again. That is called as bracketing method. Okay. He is nodding his head. I am not telling everything because it becomes too complicated. So now this is how a speech reception threshold is done. Then normal speech reception threshold is pure tone audiometry threshold. In neural lesions, there are very high thresholds because you cannot hear properly. Speech discrimination threshold score means the ability to repeat the word which is told to the patient, and sometimes he is giving confusing words. Pit, put, pot. So the ability to repeat that indicates the discrimination. So there you will get all these things, and 90 to 100 ability to repeat is normal. 0 to 30 is very poor neural lesions because they cannot discriminate. And also there is another condition called as tone decay. We'll come to that. So speech discrimination score also helps you in finding out After you do a laryngoplasty, the patient will ask, can I hear everything clearly? So if you have done a speech distribution threshold score before laryngoplasty, then you can find out the amount of cochlear result. If the cochlea is damaged, then despite your good tympanoplasty or laryngoplasty, patient may hear sound, but he will not be able to find out. I can hear, but I cannot understand. That is the problem. So your results of ear surgery can be predicted if you do a speech discrimination score before surgery, or somebody is given a hearing aid, he should be asked to do it, then that is called as an aided audiogram. In aided audiogram, if he is able to really duplicate his day-to-day communication, then that means the hearing aid is really working for him. You will find many people coming, they have given me a hearing aid, I purchased it, I'm finding it no use. Okay. So there are four types of presbycusis. So a type of presbycusis will benefit from a hearing aid. A type of presbycusis will not benefit from a hearing aid. So what are those four types? You have to read the book and pick up. So this is the everyday, day-to-day situation. I can hear, but I don't understand. So now there is another tone decay. If continuously a sound is coming to us over a period of time, some conditions they cannot hear, some conditions they continue to hear. People like us, there is a sound making it, and just trying to ignore it. So this is based on peripheral nerve inhibition, where repetitive stimuli will be merged into one. So if the time gap between successive nerve impulses is very quick, then over a period of time the sound slowly becomes completely unheard of for that particular patient in a particular condition. So it is very commonly diagnosed earlier as acoustic nerve tumor or a vestibular schwannoma. I wrote acoustic deliberately so that I can point out that it is not acoustic, it's the vestibular schwannoma which is causing pressure. Then tone decay is ability to hear a tone for 1 full minute of 1000 Hz at the PPA or the threshold in which it is measured. So somebody's Newton average is 40. You give a sound at 40 decibels of 1000 Hz for 1 continuous minute. After 10 seconds, let's say I cannot hear, you increase it. After 2 seconds, I can say I cannot hear, you still increase it. You keep increasing either till 1 full minute is over or you have reached results beyond the threshold. Understood? That is tone decay. So a tone decay, patients with precochlear hearing loss cannot hear sound continuously beyond maybe 20-30 seconds depending on the situation. Patient cannot hear, increased by 5 decibels, either till 1 minute is increased or the threshold is completely over. Normal or conductive hearing loss, only up to 0 to 5 he will continue to hear for 1 minute. The moderate 20 to 25 and severe retrocochlear after 30 decibels. By the time it comes to 30 decibels, 1 minute will be over. Or it is beyond. All these are not nowadays. Why? Because it needs participation from the patient. And by the time somebody develops tone decay, what is the condition of the internal artery meatus? The tumor would have gone. Understand? Limitations of electrophysiology. Why we are all doing tests nowadays? Why 30 years ago, 40 years ago it was not done? There was no CT scan. There was no endoscope. So that ultrastructure, ultra-anatomy of nose was lost. Then all the things in the ear, middle ear, skull base and all is because of developments of other activities. Then tone decay, which is not specific to vestibular schwannoma, it can also occur in CP tumor, trauma mumps, multiple sclerosis and transient syndrome. In all this it is seen. So there is a condition called as Bigasi audiometry. So self-recording audiometer in which again a sound is delivered continuously by the audiometer. So if the patient says he cannot do, he will manipulate it himself. So the patient is the person who is going to manipulate the audiometry himself. So because of that, we will have some problems on relying on the results given the recursive audiometry, so it is not used. So there are two types of sound, one is continuous sound, one is pulse sound. So then we will get a recording, which is again based on two indicator study. Neural lesions, continuous one will be heard, will not be heard. Will get in the first type 1, it is normal. In type 2, the pulse will come down. Type 3, the pulse falls down much more earlier than the continuous one. In 4, it will be parallel. So that could be malingering. One is retroocular renal loss, one is early decay, one is conductive. It is not very reliable nowadays because of other development. So the one which you have to know is called as impedance, in which you will get trigonometry and auditory reflex. It is done for to differentiate a conductive and sensibility hearing loss, differential diagnosis of conductive deafness, measures middle ear pressure and eustachian tube function. It gives you a differential diagnosis of cochlear or retrocochlear hearing loss. It gives you the site of lesion of facial nerve and brainstem pathologies, and it will pick up malingering. Okay. So these are the principles I think most of you know. Can I go ahead? Then middle ear pressure is measured, compliance is measured, auditory reflex is measured. You will get a type A code in the graph. Here I want to bring your attention to ECV. Below the date, you can see ECV is extra ear canal volume, which is usually about 1. If you find it more, think about a perforation. Because the middle ear cavity is added to the external ear cavity, then you will get a perforation. Okay. And if it becomes less than that, probably the patient has got wax and trigonometry is done. Because that is the one, or there can be a polyp or some other mass is there which is causing distortion of the recovery. So this is a type A curve which all of you know. There is no middle ear pathology. Then these are the 4 types of curves. Then A and AS. You note these two. A is the normal one. AS is decreased compliance in the case of autosclerosis. So the amount of stiffness in earlier Bhargaw, what is given is compliance 0.2, 0.6, normal is 0.85 to 1.2. If you want to pick up a case of autosclerosis where you want to learn early or late, if you want a thick footplate, then go for any idea? Autosclerosis thick footplate or thin footplate, laterality, if the compliance is more, that means it is thin. If the compliance is less, very less, that means it is not moving, so you get a thicker footplate. If you are beginning to learn, then you will be afraid if you take a thin footplate, suddenly you will go inside. Pick up a one which is thicker. It also helps in choosing which side to do. Whichever side the compliance is more, you do. If it is a case of bilateral autosclerosis, go for the one which has got more less compliance and more compliance. Less compliance means more disease. 0.2 is less. 0.6 is more compliance. Understood? So 0.6 means thinner footplate. So it also helps in otitis media provision, eustachian tube obstruction, choosing which side. Then this is the one which is what I told you the earlier one. If sound is delivered to the right ear, the sound will pass and cause contraction of the stapedius muscle on the other side, which is manifested as a change in the trigonometry recovery. So the sound delivered here is recovered here. That means a consensual contralateral reflex. At the same time, there will be ipsilateral reflex. With high sound, there will not be ipsilateral reflex, but there will be a contralateral. Because this stapedius, this ear is wrong. Get it? It's not easy. You may do like this. If the person who is doing it should have read it 10 times, and the person has understood it 100 times, then they will understand. Not easy. I found it very difficult initially. I don't know what to do. So sound is delivered here. The same side stapedius contracts. This is recorded as ipsilateral. sound is delivered here, the opposite side contract, sound is delivered here, this tape is also contract. If the pathway on both the sides, two axes, they should be correct. The sound should be above 85 decibel, otherwise the stability does not control. That is the mechanism the middle ear has got to prevent noise-induced hearing loss. But what is the time taken by the stabilities to contract in response to loud sound? So the time gap is such, that's why we get noise-induced hearing loss. If the stabilities have been contracting instantly, then we will not be seeing noise-induced hearing loss. Because there is a small time gap between the sound and the contraction of the stabilities, we are still seeing noise-induced hearing loss. It comes in less than 1 millisecond. But in that less than 1 millisecond, that sound is enough to cause NIH. So now, ipsilateral, contralateral, which can be normal, or if the threshold goes above 85 decibel, up to 60 decibel, okay. But after 60 decibel, if it goes beyond the output of the audio meter, you cannot do. So ipsilateral, I think both the sides will be stimulated. Unilateral, right conductive. So what happens? This stability contracts. This stability does not contract with other conductivity. Get it? It's not easy. Read again. Then severe right profound unilateral sensor neuron. Then eighth nerve lesion. If there is a left eighth nerve lesion, so what happens? This ear cannot hear. So this stability will it contract? Because of the nerve integrity, this stability will it contract? Every day you practice, you will get the answer. All these pictures are taken from Anirban resource. If you still have any doubt, you can go back. Then if there is a brainstem lesion, so impedance audiometry is not only for ear, it is for neurophysicians also. If there is a brainstem lesion, there will be crossing. So at the level of crossing, there should not be any contractions. So in the same way, facial nerve. So again in vestibular shoulder, auditory reflex decay occurs because again the same contraction of stabilities as like tone decay, there will be absent stabilities reflex after about 5 to 10 seconds. Can we do an impedance incorporated here? Yes. This is how the needle is inserted through the tympanic membrane to touch over the promontory to get the recordings. Then we will get cochlear microphonics, compound action potential, summation potential. When it is done, mainly nowadays for various diseases, we will get a recording like this. In B, you can see that the summation potential is more than 30% of the action potential, which is diagnostic of illness. There are brainstem lobe response audiometry is usually difficult to test by human audiometry because of subjective ease. You can do it in objective human audiometry, it is difficult. Some patients malingerize. You can pick up for data, you get the recordings. When there is a not reliable audiogram, you have to go for data. When it is used for detection of deafness in infants or mentally retarded or monitoring, can be done in sedated or anesthetized patients. So that's an advantage in infants. You sedate them and then you do the recordings, then you will get it. It differentiates between conductive, sensory or neural. Site of lesion in the pathology is pinpoint precise. Central auditory disorders also because wave 5, wave 6, wave 7, then you present the action. Then in very early cases where the along with the perineal tracts, if the tracts of the hearing are not completely myelinated, you may not get a recovery. So somebody may come early that the child is not driving or not intelligent and all. If you get a normal data, then you can tell them there's a delayed maturity. Okay. When recording is achieved, it is a very faint recording of the electrical activity in response to a sound stimulus. In all of these tests, a sound is delivered to the ear, then the average potential of the electrical changes which occur in the nervous system are put one over the other. That is called as averaging by the computer. So then they will get a recording. Then again there will be so many other neurological stimulations called as background noise. All that has to be eliminated to pick up what you want. So that will give you the cytoplasm. So stimulus 60 decibels above the frequency threshold is given. And then you will get these waves. Wave 1 is distal cochlear wave. Wave 2 is proximal cochlear. Wave 3 is cochlear nucleus. Wave 4 is superior. Wave 5 is lateral meniscus. Wave 6 and 7 are inferior cochlear. There are many books giving many sides of different ones. So don't go further. There will be some differences. So this is the pathway in which you get wave 1, 2, 3, 4, 5. You have to remember each line to remember the site of lesion. Then wave 4 is the most important one because it's easily identifiable, easily duplicatable, and easily recognizable. The time taken for each wave to appear after stimulus and the gap between two sites is noted. So there will be a gap of 4 milliseconds from wave 1 to wave 5. And if it is beyond, that means there is something there which is delaying the sound. And if you compare one ear with the other ear, which is called as inter-aural latency, then within the same ear it is called as inter-peak latency. So the latency amplitude are measured. Then there is what is called as stack behavior, which is difficult. I don't think it's necessary for you as well. Then there is auditory steady state response for the sleeping implant or a sedated body for predicting candidacy of cochlear implant. In very early intracranial phenomena may not cause changes in data. That is the reason why they now insist on a contrast amount. Right? So why all these things are telling you when it is not done? Sometimes it will be helpful in some other thing. Earlier, why it was devised was something now. Kumar is another gold standard for retina tumor. Earlier, when I was reading, they used to do what is called CT sonography, do a lumbar puncture, put air in the lumbar space, tilt the patient, let the air go into the internal artery meatus, and then that is called air contrast system metrography. So that used to go and show the tumor. So it's an invasive one. You may put infection. Patient already has got one problem, and if you put meningitis, you had it. So all these things are just like museum. You have to remember it. Then autoplastic emissions. All of you know about this. Absent autoplastic emissions, there is no outer head cell. It indicates deafness. You remember this. There can be no autoplastic. There can be spontaneous both. So the result will be pass. Pass means everything is normal. Refer means you have to refer for other things. So there is spontaneous growth. So there is no single test to localize a site. Sometimes you need one or two tests to collaborate one another. Audiological data is needed for prognostic tests. Early identification is possible for early measures because if somebody is on chemotherapy for carcinoma, so stopping from developing deafness, you have to do autoplastic emission whenever the disease is flattened. So this is an audiology by ENT surgeon for ENT surgeons only, not for audiology. Thank you.
Thank you very much. Covering such a vast topic in short time is great. Now we move from the words of knowledge to the words of wisdom. Okay? Before that, I would like to request Dr. Satish sir to present a moment of Anand Acharya. Now, the next session would be words of wisdom, that is tips or basic clinical presentation by Bhargaw Ilapakurty, and thereafter we'll conclude by taking a group photo back. The professor will be giving a few tips to the example programs, and then after we'll conclude the session by taking a group program. Thank you very much, sir. Now, I'd like to request the professor to say a few words. Maybe our postgraduates have about what we can do. Okay.
Only postgraduates are really repetition. But I don't know. Anyway, of course, anyway, only to do that. When you go to the exam, when you go to the exam, yes, it is have your own have a name. We have to change the public to other. I and the primary advocates are given to the next group. So we don't do such things. And this particularly I see in the group challenges that we also take account of form and shut of form means then I have project and small word. So we teach it because we have to elaborate the fashion. We teach it as you know. And then basically the exam on that day. So I expect you to be polished. Don't look at the exam. Even if you say something completely directly opposite